It's a Northwest Lifestyle Weekend on Como News. IRG's Health Talk continues.
All right, our next guest is Dr. Johnathan Hodax, a board-certified orthopedic surgeon specializing in minimally invasive surgery for the knee, the shoulder, the hip, and fractures. We're going to talk about the patella today, Shannon. Patella, better known in layman's terms as the kneecap. Is it a bone? Is it a joint? What is a patella?
The patella, Tom, you're right, it's called the kneecap in layman's terms. It actually is a bone. It has connection to the quad tendon, and then it also has a tendon that attaches to your tibia bone. It's very important for knee mechanics. It acts as a fulcrum to give strength advantage to the quadricep muscles. And if you have patella problems, you have difficulty walking, climbing stairs, moving from a sit to stand, it's a very important bone in your knee.
All right, Dr. Hodax and Shannon O'Kelly.
Dr. Hodax, welcome. How are you?
Thanks so much. I'm doing great. How are you? It's great to be back on.
I'm doing fantastic. Thanks for joining us again. In the past, we had a conversation. You're an orthopedic surgeon. Your area of expertise is essentially sports medicine, knees, shoulders, et cetera, et cetera. One of the areas I saw when you talk about your expertise is you have an interest in patella instability or dislocations of the patella. And, just a couple of days ago, I got a call from a former patient whose son was out running around, participating in some conditioning activities, socially distancing, by the way. And seems like what they described is the young person might have some patella instability, or even over the phone when I talked to the mother, I was concerned about the dislocation, and particularly in young athletes and athletes that participate in traumatic or high contact sports. Sometimes the patella becomes dislocated or unstable. So let's talk about the patella. Let's set it up anatomically. Why is it such an important little bone in our knee, and what's its function, and how it becomes unstable or dislocated?
Sure thing. Yeah. So your kneecap, your patella is really important. It acts to really strengthen your quad, your ability to extend your knee out straight. And it provides a lot of mechanical leverage for that muscle to fire. And so your kneecap, we hear about kneecap breaking, we hear about kneecap dislocating, we hear about kneecap arthritis. There's a lot of things that can happen. But a kneecap dislocation, a patellar dislocation, or just instability where it doesn't come all the way out, but you feel like it might, happens when the kneecap falls out of its groove in the end of your thigh bone. We call that groove the trochlea. And almost always when this happens, it's coming out to the outer side of your leg, the lateral side.
Yeah, and it's a fascinating little area of the body because it is so important. It provides such, if you didn't have your kneecap, your quads basically wouldn't have any strength. So it works as, from a physics standpoint, a significant fulcrum. And it glides
exactly
up.
Right.
And it glides. So when you bend and straighten your knee, that kneecap is moving up and down that trochlear groove you just described. But it also can move a little bit medial and lateral. And when it goes lateral too much, that's a subluxation, and it goes significant laterally, that is a dislocation. What are the signs and symptoms, and how does this occur in your experience with your patients?
Yeah, so the situations that you're describing are really accurate. So sometimes we see this as a non-contact pivoting injury, where somebody is twisting or rotating awkwardly. They feel like their knee buckles. They feel like something gives or pops. They go down, and by the time they hit the ground, the kneecap has already found its way back into its groove. That especially happens if you fall in a way that your knee straightens out. Sometimes it's much more obvious, and you go down and that kneecap is still sitting on the side of the knee. And unfortunately, I think most of us have seen some disturbing videos on the internet of things just like that. So that's the big difference between a subluxation, where it finds its way back home, or a dislocation, where it finds its way out and does not come back. The most challenging thing about this is with patellar instability, with a kneecap subluxation or dislocation, there can be a sense of a pop, there can be a sense of instability, the knee swells suddenly, and it can be a contact or a non-contact injury.
And what is the easiest way to figure that out if you're in an examination? I mean, how do you determine subluxation, dislocation, kneecap versus any other internal derangement inside the knee, such as an ACL?
Right. So that's where our physical exam comes in. Some patients have a good sense of exactly what happened. They can tell you, I felt like my kneecap went over. Some people just don't have that sort of sense. But getting your hands on the patient, seeing what happens when you move their kneecap around, what happens when you rotate their leg or pull their shin forward, the exam maneuvers that we do for an ACL tear, like the Lockman test or the pivot shift, which are some of the things that your doctor will talk to you about in the office or try in the office to get a sense of how stable does your ACL feel, how stable does that kneecap feel? And a lot of the times we're going to follow this up with an MRI to be absolutely certain and to look at severity too.
More with Dr. Johnathan Hodax and Shannon O'Kelly after this time out on Como.
It's a Northwest Lifestyle Weekend on Como News. Here's Tom Hudler and Shannon O'Kelly with more IRG Health Talk.
We continue talking about the patella and other possible problems with the knee with Dr. Johnathan Hodax and Shannon O'Kelly.
Dr. Hodax, thank you again for joining us here on Health Talk. We're talking about patella or kneecap subluxations or complete dislocations. You were just describing kind of how you're going to assess this from an examination standpoint. But let's say someone dislocates or has an unstable patella. What are their options at that point in time?
Sure. So the first thing is that patient is uncomfortable and we want to get them feeling better. Starting out with some gentle motion, bracing, crutches, ice, anti-inflammatories, all the basic things. We want to get that acute discomfort. It all comes down to, is this a consistent problem that's not going to go away? And that's when you end up having a conversation about a surgery.
So when you look at this from a diagnostic standpoint, as that kneecap slips out or sublux or dislocates, there can be some trauma. I mean, let's talk about the medial lateral retinaculum, the connective tissue on each side that holds that kneecap in place. And also it has cartilage. And sometimes when that kneecap comes out, that cartilage can get a divot or a dent or fracture. Talk about that.
That's right. So almost every time that a kneecap finds its way out of the groove, the kneecap moves its way to the outer side of the knee. And along the inner side, there's a ligament that runs from your kneecap to the end of your thigh bone. We call that the medial patellofemoral ligament, or the MPFL. That can be stretched, strained, or frankly torn. In addition, it can pull off a piece of bone as it goes. Or as your kneecap finds its way out of the joint, just the grinding of your kneecap against the side of your thigh bone, it can knock off a piece of cartilage. Now, if there's a free piece of cartilage floating around inside the knee joint, that's absolutely something that we're going to have a conversation about. Do we need to do something about that to get that piece out to protect your knee? That MPFL tear, that's another option and something that we treat either by repair or by putting in a graft to reconstruct that ligament.
This is done minimally invasive. I noticed that that's your area of specialty. So is this a procedure that's going to be done through the scope, outpatient-wise? Pretty easy recovery. Let's not use the word easy, but recovery's pretty good.
I appreciate that. Yeah. No, so there's actually a lot of different surgeries for an unstable kneecap. They range from just finding that loose piece of cartilage, if there is one, repairing that ligament or replacing that ligament with some donor tissue. And those have small, minimally invasive incisions and you're done with a scope. For people with repeated instability, we're going to get some more advanced imaging. We're going to look at your anatomy and your alignment and figure out, is there something that's leading this kneecap to be too easily pushed out of place?
Wonderful. As we wrap up here, I just want to finish with a thought. There are options for patients that have chronic dislocations, subluxations, pretty good outcomes after surgery then?
Yeah, absolutely. We're looking at, for almost every patient, a full return to sport. For almost, greater than 90%, we're keeping that kneecap from dislocating again. But most important is figuring out, do you need the surgery and which surgery do you need? So we're not operating on people who don't need it. We're just looking to help people get back in action.
Great information. Dr. Hodax, again, thank you so much for joining us here on Health Talk. Have a wonderful day.
Thanks for having me. This is always a blast, Shannon.
All right. We've been hearing from Dr. Johnathan Hodax and, with the Seahawks injuries and injuries around the NFL in general, Shannon, the patella and the knee. As Howard Cosell used to say, the knee, always the knee. And it's hey,
take me back, Tom. Take me back.
But yeah, the knee is such a point of emphasis when it comes to playing football.
Oh my gosh. I mean, the knee is probably the most common injury we see in football and other running activities. A lot of stopping, starting, cutting, twisting, and then you have the contact factor in there. And yeah, the knee can be injured multiple ways: ligaments, meniscus, patella, tibial plateau fractures. I mean, it is a complex joint in its own right and susceptible to injuries, but you can strengthen it and you can condition it so you can have some safety and some protection.
All right. Thanks to Dr. Hodax. Dr. Eric Pang joins us next right here on Como.